our geriatric resource course attendees for this year. So we have people from a lot of different backgrounds. So we sort of the course, just so you know, sort of we progress from healthy aging through end of life. And so this lecture, we're hoping to touch on some of those issues that get a little bit closer to end of life where you're having to think about long-term care options, both inside and outside of the home. And then sort of a big issue we always try to emphasize to is who pays for what. So, you know, people are less surprised when they get there and find out nobody pays. So I'm going to let you take it away. This is Dr. Natalie Kayani, geriatrician at Summa Health System.
Hello, hello. Okay, I've never done a share screen before, so I'm going to try it and see if I can figure this out. I figured it out. Can you see it? Okay.
Yes.
And then, can you still see me or just the slides? Can you hear me?
Yes, we can hear you.
Okay.
And yes,
I can see you.
Okay.
Okay.
And now you still see my slides because I have a completely different screen.
Yes.
Okay.
Yeah.
Yay.
We see your primary slide, and we also see your next slide.
Aw. I wonder if there's a way to hide that.
If you go to display settings up there at the top.
Swap
Yeah,
presenter.
try that one.
Yes. Oh, yeah. Okay.
There
now
you go. Perfect.
Yay. Okay. Thank you so much. Yeah, so I'm Dr. Kayani. I have been in the Department of Geriatrics at Summa for 23 years and still love it. Been through lots of hard times, but the hardest time is that there is a shortage of geriatricians across the country, and that is always a struggle. And I've been in the long-term care space on and off. I say the last 5 years, I've done a lot of nursing home work. So when Sue asked me to give this talk, I felt very comfortable because sometimes she asked me to give talks and I'm not very comfortable. All right, so this is what I'm hoping to cover in this hour. The characteristics of the differing levels of care, how much it costs, who pays for it, a little bit about the ratings, and a little bit on regulations. So, and I found a bunch of funny memes, so I just threw them in there to break this talk up. But this is probably, I don't have any tattoos, but I think in my mind, this is going to be me when I'm in a nursing home. I'm mentally with them. All right. So these are the levels of care I plan to cover and the initials that I'll use: independent living, assisted living, or some people call them ALFs, assisted living facilities, memory care units, skilled nursing facilities, long-term care, which you'll also hear called custodial care or intermediate care. I don't talk a lot about inpatient rehab, but that is another option for care, and long-term acute care. I'll touch on those a little. And again, to try to make it a little more interesting, I have some cases to talk through. So here you have a 93-year-old woman who presents to her primary care physician. She complains that she's been lonely for the last 3 years after her husband's death. She also has a lot of friends, but they've died or moved to facilities. She doesn't meet the criteria for clinical depression, but she is lonely and wants to kind of downsize, and she's trying to figure out where she should go. She has no dementia. She's independent with her activities of daily living, which I'll review on the next slide because I've been told that not everybody in this group is a medical background. So I'll explain stuff that I think they might need to know. And so she's looking for recommendations on, what are her options for living? And she'd be somebody, so for activities of daily living, the basic ones are bathing, dressing, toileting, ambulation, transfer feeding, and then your instrumental are the things that you need to be able to do to stay independent. So talk on the phone, drive, grocery shop, meal prep, housework, meds, and finances. So she's somebody who would probably be great for an independent living level of care. I'll tell you that I was a little depressed when I looked up the definition on Google and it said 55 and older, because I turned 55 in 3 months and I thought, I am not senior. But as a lot of us know, we all age physiologically differently, and sometimes it's lifestyle induced and sometimes it's just health induced. So if there are people that at 55 have a lot of chronic health issues and do need that level of care, or do need a higher level of care. But for independent living, you have to be independent. You have to not need help with ADLs and IADLs, because really what they offer is some socialization, some activities. Some of them do congregate meals. Some of them have transportation that will take people to grocery stores or doctor appointments, but some of them don't have a lot of any of that. More activity, socialization, and not a lot of extra support. All right, our next patient is 73-year-old woman. And I guess if somebody has questions along the way, I think isn't there a way to like raise your hand or something?
And I'll monitor the chat too.
Okay, good. Yeah, so just bust in with any questions along the way. But I know we're going to have time at the end, I think, for a big open question session. 73-year-old woman, status post hip fracture, who's about to discharge from rehab. So prior to the fracture, she was starting to have some struggles. She was living alone. She used a walker, but she couldn't drive anymore, and she was having trouble getting groceries and cooking, and she was thinking about moving. The physical therapist, the occupational therapist felt like she could manage her activities of daily living at this point, but they agreed that she needs some help with meals, transportation, and housework. Speech therapy said they thought she had a little bit of cognitive impairment and felt like she should probably have some assistance with those more difficult tasks, medications, and finances. So she'd be somebody perfect for assisted living level of care. Again, 55 and older, needs minimal assistance with ADLs, IADLs, especially they'll often provide medications and meals, and some will do bathing. They usually have staff that are available 24 hours a day. These are not nurses, though. It tends to be aides and caregivers. There are some buildings that provide 24-hour nursing care, but not all of them. They also have socialization options, activity options, congregate meals, and there you can often get meals more often a day. Some provide transportation, again, more to grocery store and doctor's appointments, and some will do, like fun activities that they'll transport people to. And most of them have nurses that provide medications. A lot of them you'll sign up and you'll have a base pay for the room and the board, and then they'll do kind of a la carte pay for, if you want a nurse to do this and a nurse to do that and the aides to do this, then you pay more for each of those services. And I just had somebody recently tell me that some of these buildings are getting a little crazy at the amount of things they think about that their staff might have to do to help and charging for it. So it's something you definitely have to be aware of when you're signing up for this. Our next guy is a 78-year-old man brought into the Summa Senior Health Center for an assessment of his memory loss. His family reported he'd wandered twice from his home in the last month because he's not recognizing it at times. They have to remind him to bathe. At night, he's rummaging through drawers, and his wife's just exhausted, and she wants to put him in a facility. So she's coming to you asking, what would be appropriate for him. So he might be okay in a memory care unit. Memory care is an assisted living facility, has the same rules as assisted living, but the people that live there need 24-hour supervision, and they're typically locked units. They're more appropriate usually for people that wander. I've been to some memory care units that don't offer quite that level of care for, they're more they're looking for patients more that just need extra activities, extra programming. They don't necessarily want somebody that wanders, but the majority of them in this community are locked and are meant for people that wander. There are a lot of people live in assisted living that have dementia and can do okay in that setting. Like I said, I usually say the hard line for memory care unit is wandering. And there's typically a little more support in these facilities, but not always. Again, I remember touring one that I said, well, you advertise yourself as memory care, but they won't take anybody that has any behaviors at all or has any kind of wandering stuff. And I'm like, well, what do you do? And they said, well, we have extra, activities. So you always have to ask those questions. And they typically do have more programming. I think I've already mentioned that. And then here's a man who's 82, found down at home by his neighbors. His home was found to be in disarray, hoarding. He had a refrigerator, didn't work. He had food on the counters, medications all over the home. We actually just had this guy in clinic, so that's why I used him. Not that that picture is not him. I found that on Google, but we had this case in our office. So after hospitalization and rehab, everyone felt he was just too physically impaired to return home. And his daughter lives out of state, and she's, asking the team what's the most appropriate level of care. So this would be someone appropriate for a nursing home level of care. And when you go to nursing homes, most of them have a wing that they dedicate to the skilled care. So these are people coming out of the hospital who need a skilled person to take care of them, a physical therapist, an occupational therapist, an RN, some combination of those professionals. And it's a short-term thing. It's called short-term skilled rehab, SNF, skilled. You'll hear all those different terms, but they all mean the same thing. And then the rest of the building is the long-term care parts. And again, you'll hear this called long-term or custodial or intermediate level of care. For the SNF patients, in order to get to that level of care, you have to have been in the hospital for 3 midnights. I still to this day don't know why it's 3 midnights, but I have to be there for 3 midnights in the last 30 days. And so sometimes people are in the hospital, they're sick, we get them through whatever it is, but they're just really weak and too weak to go home, don't have enough care at home. And so they'll come to a skilled unit. And sometimes they'll say, I think we can make it at home. And families will say, I think we can make it at home, and they'll go home. And as long as it's like within that 30-day discharge and it's for the same illness, they can often still go to the nursing home as a second resort if that first option didn't work for them. The skilled needs, like I said, can include nursing and or therapy, which I'll talk about in the next slide. And most of them offer daily therapy, meaning during the week, 5 days a week. Some will actually do 7 days a week therapy. And patients usually do an hour or two. Sometimes they'll do an hour with PT and an hour with OT in a day. And they have to have a reasonable expectation for improvement. And I always tell patients and families, because they'll say things like, oh, I heard I have 100 days here. And we always tell them up to 100 days. And it's based on kind of where you started, not where you started, but what your baseline is. We're trying to get you back to that baseline. And as long as you keep improving, then your insurance company will keep paying for it. But at some point, if everybody keeps working with you and you're really not making any progress, then they don't want to pay for it at that point. So it tends to be a short stay, usually less than a month. And then if needed, people can stay long-term. The guy in my example was more of a long-term patient. So they can still get nurses and therapy, but they don't get it to the level that when they're skilled. They'll get it a couple days a week they could have therapy, but they do have nurses still handing out medications all the time. And they have to have either need either hands-on assistance with their activities of daily living or 24-hour care. So some people are in a nursing home more for the dementia than they are for the physical disability, but the majority of people are there for both. So skilled needs, there are nursing needs and therapy needs. So whenever the insurance companies are looking at you'll hear these terms that social work will use that say needs a skillable need in order for the insurance to pay for this. So for nursing, if you get a new feeding tube placed, there's time where patient has to adjust to the feeding tube. We have to slowly increase the amount, make sure their stomach does okay with it, and everything their bowels do okay with it. And then we have to teach the families how to do this and how much water to put in there. And we have to watch all their electrolytes. So it takes a little while to do that, to get somebody up to where they're supposed to be, and then to teach family how to manage it at home. But Medicare will pay, the full 180 days for a new PEG tube. We try hard in all the buildings I've been in to not use up all those days because someone only gets 100 days for the whole year. So we try to get people out, but I'm sure there are buildings that try to keep people longer because that's how they get paid. And then wounds, they say it has to be stage 3 or stage 4 wounds that are deep and have to be packed with gauze and require someone to go in there frequently to make dressing changes. Those kind of wounds you can count as a skilled need versus, a wound that just is surface level and has a dressing on it that can be changed once a day or every few days. That's not a skilled nursing need for nursing home level of care. And IV antibiotics. So when people need IVs for 6 to 8 weeks, they can go to nursing homes to get those. Although nowadays we are trying to move a lot more of those people into the home setting and trying to use home care and family to get the antibiotics instead. And then the therapy needs, usually, insurance will look at how they're doing with not just insurance, but we do too. We look at, how are they doing with walking, and do they need help getting up, transferring from sitting to standing, and how much help do they need, and what kind of help do they have at home. So people that live alone will need to reach a much greater independence level before we discharge them versus people that have family at home. I know my dad had back surgery, and I was watching therapy work with him, and they kind of need to help him up a little bit. And they were saying, well, he could go to a nursing home to get rehab. And my mom and I are like, nope. She's a nurse, I'm a doctor. I'm like, we're taking him home. And like, we can offer that level of assistance and therapy. So again, it just depends on your situation or the patient's situation, whether or not they need to stay somewhere like a SNF. And then, as I said before, I'll just mention these two as other options. To go to a place like inpatient rehab facilities, such as the Summa Rehab Hospital, patients do need to be able to tolerate 3 hours of therapy a day. In order for that level of care, they have to be a lot more functional to go there. And then the long-term acute care, the one we use is called Select. Select takes people that are very complicated medically, complicated physically, typically people that have long-term ventilators or, tracheostomies hooked up to ventilators, or they need total parenteral nutrition, which is basically food through an IV. They can't eat, and that food through the IV, you have to monitor a lot of electrolytes and fluids, and they really need kind of this acute care, but it's a chronic thing. They have this long-term acute needs that they're going to have long-term. People with burns and extensive wounds will often go to that setting.
Natalie, Mary has asked a question. Do you see the
Yes.
Medicare Advantage plans covering the same number of SNF days as traditional Medicare?
Yes, I think they will still cover 100, but I think I'm going to get into this about how because they still have to follow, kind of have to follow Medicare guidelines, but they are actively managing these patients. Somebody on Medicare, Medicare just says, these are the rules, follow the rules. And then periodically we'll come in and do audits. And if you were breaking the rules, then you get a big fine and might get your privileges revoked. Versus Summa Care Insurance, for instance, or Anthem or whoever, United Healthcare, they will actively say, send us copies of your notes and your charts and your therapy and your nursing and your doctor. And, we'll decide whether or not we think they still need that level of care. So they tend to, because they're actively involved, they tend to cut people quicker than the teams will in the buildings often. But yeah, I'll just leave it at that. So who pays for all of this? I was proud of myself for making this. It's not very pretty, but I use one of the PowerPoint options. So all the way to the left is independent living and the purple is private pay. So independent livings are 100% private pay. As you move towards the right, and I tried looking up these numbers, they're a little tricky to find. So this is not exact, but somewhere maybe around 75% of assisted living is private pay and around 25% of the beds are paid by Medicaid. And then once you move to nursing, it's more, you start off as private pay until you have no funds and then you apply for Medicaid. So eventually Medicaid ends up taking over. And that it says long-term care on my slide, but it's really nursing home. They included skilled time on those numbers. I had trouble finding exactly what I was looking for. All right, so who pays the bill? So again, this depends which site I read. It was a little tricky, but somewhere around 65% of the bills for nursing homes are paid by Medicaid, and that Medicare coverage is only for skilled. So people are always shocked. They come into the center and they say, I want to put my mom in a nursing home and we're gonna run it by our insurance and see what they'll cover and how much they cost. And we always have to tell them, there are no health insurance plans at all that cover any nursing home care. It is all private pay until you spend all your money, use up all your money, you sell your house, all your assets are gone, and then you can apply for Medicaid and Medicaid takes over the cost. So this slide again shows that Medicare payment is SNF care. And I already talked about the private pay. And then long-term care insurance is getting to be a little more popular. So what I find with a lot of these is that they pay a fraction of the nursing home care. They don't cover 100% of it. I still like these plans. In fact, I got one for myself when I turned 50 because they'll also cover care at home. So you can get some home health aides using this long-term care insurance, and doesn't necessarily mean you have to go to a nursing home. And again, it doesn't cover everything by any means, but it helps pay the cost or pay the price. And then the VA also provides nursing home care and will provide funds for that level if needed. They don't cover, again, it's a little trickier. It depends. There's a lot of factors that go into it, but, and they do have a few VA nursing home facilities. I think we have one in Sandusky that I know of. So for skilled care, there's Medicare's Part A and B. So A bundles the payments that pretty much covers everything while you're there, 100% for the first 20 days. So we've definitely had a lot of people who will say, day 21 is coming up and I have just straight Medicare and I do not want to pay the copay. So they will often try to get out of there before that day 21 kicks in. And then for physician services, like when I bill for my visits at the nursing home, Medicare pays 80% of that. So there's some copays for patients. And oh gosh, once they're in long-term care, room, board, nursing services, again, private pay until funds are depleted, and then Medicaid takes over, or if you have long-term care insurance or VA, they can pay for some of that. Physician services are the same. And then therapy services, they can still get therapy, but now it switches from Part A to this Part B plan, and that does have some caps a lot of times, and they don't see patients as often once they switch to Part B therapies. It's usually twice a week that they'll work with them. And then x-rays and labs, again, not covered under A now, they're covered under B. And meds I read is under D, which I actually did not know. Oh, here's a funny one. So this just got sent to me earlier this month. This is one of my friends, a former partner, sent me this email, or not email, text. My girls are asking me about nursing homes, and I was telling them about how people get help taking baths and going potty. And her little daughter says, "Do we live in a nursing home?" I thought that was cute. What is the monthly cost? So independent, assisted, and memory care. So I use this, I've been using this forever, this website or app. There's a company called Genworth, their life insurance company, and you can go in there and put your state, your town, your county, and ask them what the median prices are for all kinds of things. They have adult daycare and assisted living, home health aides. And so that's where I got these numbers from. So private pay median amount for Akron is $5,000, but I've heard of $7,000 a month, and I mean, I've heard all kinds of things. I've heard of $3,000 a month as well. So I guess, yeah, median is 5,000. So private pay covers all of that. Many years ago, they kind of got smart. State of Ohio, we used to have, we've had the passport program through Direction Home, the Area Agency on Aging, that helps provide that nursing home level of care in the home with all kinds of things, home health aides and lifeline buttons and medication dispensers. They offer a lot of things to keep people in the home. And I think somebody realized that it's actually cheaper to have people in an assisted living than it is to bring all that help into the home, because there's, one aide can take care of 15, 20, 30 patients in an assisted living versus one-on-one care at home. So they have opened up more and more slots over time for this assisted living waiver program through Medicaid. And usually the way that works is if you go to an assisted living, the ones that are super fancy and super expensive and can get people to pay that much money and will not offer any Medicaid beds. They'll just, because as long as they're filling their beds and they're happy with the amount of money they're making, like, they won't offer Medicaid beds. Versus there's some buildings that honestly, it's like the nursing homes that they're just older. Like, some of the older ones have fabulous staff and excellent care, but the building is older. And so some people walk in and see old building and say, "Oh, I don't want my mom here." And so some of these places that take a lot of Medicaid patients, like I said, my opinion is it's just because it looks old and they keep building all these fancier, newer, some of these assisted livings I hear have like bowling alleys in them and bars, and so a lot of them, like I said, aren't offering Medicaid beds. So, and then there's at least one facility I know of that's almost all Medicaid. But I think at the moment there aren't a lot of openings. There's a wait list. They have rules, like you have to private pay first for a couple years before you can switch over to Medicaid. So we basically tell families, like, you're going to have to talk to each individual building because they have different rules. We keep a list in our office of which facilities we know have Medicaid beds, but in terms of, do they have openings and how much they require payment up front is up to them. And then cost of nursing home care, again, these are just median numbers that I could find for semi-private and private rooms. And again, it costs more because those patients need more care, and they need more aides and higher nursing staff, and there's just a lot more care to be provided. So it's so expensive. And then I had a friend who had 24-hour care at home. Now it's been over 5 years, but over 5 years ago, she did 24-hour like private paid duty aides. They weren't even nurses; they were just home health aides, and she paid $10,000 a month. So even though these numbers look crazy, it's even more expensive to try to keep someone at home, unless you have family that can supplement some of those 24 hours. But if you don't and you're private paying the whole thing, it's super expensive. And then how much does a nursing home get from the insurance companies? So this is why people don't want the Medicaid beds if they don't have to take them, because they get about like half the amount of money for a Medicaid bed as opposed to a Medicare SNF stay. And so $240 a day was what I found. And then if they're short-term skilled, the facility's getting about whatever, $600 from Medicare and Summa and all of them for that bed. And the patient's copay then is like, can be around $200 a day at day 21. So now I'll tell you that's Medicare's rule, but companies like Summa when you have a Medicare Advantage plan through them, they can make up their own rules about the copays. And some of them have copays day one. And I know like with Summa they have different levels of care, you know, the ruby and the silver and the gold. And so depending which plan you have, you'll pay different copay amounts at different times. So there's so many variables in this. I don't remember what I had on this slide. Medicare Managed Care. So I've already mentioned there's a bunch of companies that provide Medicare services, and I don't know if you guys have talked about Advantage plans, but essentially Medicare says to these companies, you know, you can manage these patients and we're going to give you this much money like per patient per month, and you manage it however you want. So they can kind of bend the rules. I know a lot of them are starting to bend the rules when it comes at, that's my last bullet here. When it comes to that 3-day hospital stay, Summa has been doing it a long time. And it's nice to have like an insurance company that works right down the street and that we can talk to. So they've been doing this a long time, and finally other companies are catching on. So when someone shows up in the emergency room, they've fallen, everything hurts, they can't walk, they're in pain, they get CAT scanned and x-rayed up and down, there are no broken bones, there's no heart attack, there's no pneumonia, like it's really, they just fell and they're bruised up and they don't have anybody that can help take care of them and they need therapy. Those are the perfect kind of patients that can waive that hospital stay. There's no reason to be in the hospital for 3 midnights and yet can't take care of themselves. And if we send them home, they're probably just going to lay there and then end up back in the hospital even sicker. So insurance companies, again, got smart and like from the emergency room will waive that 3-day hospital stay and they can go right to a skilled unit. And then while they're there, like I mentioned, they aggressively manage this length of stay, and they usually do it again through faxes. They'll say fax us all their notes, and then their team reviews notes and decides whether or not to continue to certify that patient for therapy. They can hold down cost by controlling services. So again, some will do 5 days a week, some will do 7 days a week. They can structure their plans so that they have fewer co-insurance free days or higher copays. There's, again, a lot of different options. And usually the facilities will contract with the different insurance companies to get this rate. You know, if we take your patients, you know, or if you take our patients, then we'll pay you this rate per day to take care of them. I know like Summa has restrictions. They're contracted with, I think it's somewhere around 12 facilities in our area. And so they encourage patients to go to those facilities, and then they'll usually pay those facilities a little bit higher rates because they have good working relationships with them. but patients can still go other places. They'll just often pay higher copays. So, but again, a lot of it, it's so individual and variable, and it keeps changing. And I hate that everything keeps changing because I can't keep up with it. So here's a case that I have where we're trying to figure out like what, can he go to a facility? So 55-year-old man brought to his PCP by his wife. She says, he's got dementia. He can't remember anything. I'm doing all of his instrumental activities of daily living, and I'm just exhausted, and I need to put him in a facility. And then the doctor goes in, does their whole assessment, and talks to the patient, and he decides, you know what, this is not dementia. This guy has selective hearing loss. So he's just not listening to his wife. He just doesn't want to do all this stuff. And he doesn't remember what she's talking about because he's not listening to her. And she's telling him, I need you to do this, this, and this, and this. And he pretends like he can't hear her. And she has always cooked, cleaned, shopped, managed the finances, medication since the day they were married. And I have patients like this, men that are like completely IADL dependent since they were 20 years old. But she's tired of it and she wants to put him in a nursing home. So can he be admitted to a facility? So who approves these levels of care? So for independent assisted memory care, there really is no approval process. You're privately paying for this, and she could probably put him in the home if he'd be willing to stay. But if Medicaid's the payer, you can't do that. You have to have this thing called a level of care determination. So physicians will get this document saying, does this patient meet this level of care? Is this an appropriate level of care? If we're going to pay for it, it needs to be, medically appropriate. So, and it's the same with nursing homes. You need that level of care assessment by a physician. So for when they go to skilled or rehab, physicians have to sign off on this piece of paper. It says they meet the Medicare requirements. They need to be at this level of care. I know I've run into problems at times where the facility says, they have Medicare and we want to keep them another week. And I'll say, for what? And if in my mind it doesn't meet that level of care, I tell them I'm not signing this piece of paper. That's Medicare fraud, and I'm not signing this paper because they don't need to be here and I don't want to go to Medicare jail. That very rarely happens because the facilities also don't want to go to Medicare jail. So, but the physician is ultimately held responsible if they're keep signing off on this, that this patient meets this level of care and they don't. And then for the Medicare HMOs, the commercial providers, there's often like people in the background that are approving this level of care. To get into the facility, they have to have something called a PASR. It's a pre-admission screening and resident review. And I've heard there's some NPs in this group, so I know that when you're on the floor, sometimes the teams will say, hey, we're ready to discharge this patient. Why aren't they being discharged? Why are they still here? And you'll hear social work say, oh, I need a PASR. I'm waiting for the PASR. And so the PASR is something done by the Area Agency on Aging. They have to pre-screen to make sure that people that have intellectual developmental disabilities or serious illness are appropriately screened and proved, because for a long time people were just being locked up with mental illness against their will, not appropriately being treated. And so the government stepped in and said, like, we can't lock up untreated people and not take care of them, so we need to make sure that this is appropriate. And then they also do a sex offender registry search, and I looked into that a little more because I know that that's done and I see it on there in every patient. And I thought, well, what do they do what if they are a sex offender? And that doesn't mean they can't be placed. It is something though that they have to do. And then if they are, that facility has to be sure that this is an appropriate place for them and look up like what was their offense, and decide again, is that something that we're okay with and okay with putting other people at risk if there is a risk. So again, it doesn't mean they can't be placed, but it does have to be done before they're placed, before it's approved. And then for long-term care, it's very similar. They have to meet this. It's similar, I guess, towards the bottom. They have to have the PASSR. They have to have the sex offender registry. But the top part is a little different. They have to meet this level of care, this intermediate level of care, which means they need help with 2 or more of their activities of daily living, not the IADLs, but the ADLs. Like they have to need help with bathing, dressing, transferring, ambulation, toileting, or 24-hour supervision. So again, people with dementia that just need somebody watching them for safety reasons. And this level of care is established by the Area Agency on Aging and then signed off by a physician. And then they also have to have a valid history and physical done within 30 days of admission, which can be tricky sometimes for patients. I've seen so many different cases where people haven't seen a doctor in a long time and they can't be admitted to nursing home until a doctor has seen them and approves the medications and does a good examination of them. And of course, they have to have a payer source. So that's part of that approval process to get into a facility. And sometimes if they don't have enough money, but they're not yet on Medicaid, the facility will work with family to start the application process. And a lot of them will take people pending Medicaid. So they'll take them while they're kind of waiting for that to happen because it can take a long time. All right, so how long is a skilled stay? So the Medicare says the maximum is 100 days as long as they meet skilled criteria. And if they use up their 100 days, but they go home for a 60 days spell of wellness, so they're not in the hospital again, then it does recycle. The Medicare HMOs, what I've read is it's supposed to be the same, and I've never seen that it wasn't the same. But like I said, they just manage it. They manage it. Medicare doesn't manage this. And then I read this. This was again another thing where I Googled it, and because it said that commercial plans can vary, but they're often 100 days. So I don't know what that means. I've not seen that in my practice, but I know there were some insurances that kind of did their own thing. Or I've seen different insurances that I'm not as familiar with it, kind of do their own thing. But my understanding is when Medicare makes the rules, everybody else has to follow them. And then people ask this a lot of times when they move to these different places. Can I still keep my own doctor? Do I get to keep my doctor? So in independent living, definitely. I don't know any physicians that, well, actually, I'll take that back because we do provide care in independent living at times. So, but usually people live there and they just go to their own doctors. Our house calls program will take care of someone in independent living who is homebound. But most people live in independent living are not homebound. But if they are, then like at least our group, I think some other groups will do that as well. And assisted living, I put maybe because some people want to keep their own doctor and they have somebody that can transport them, or some of them still drive in assisted living. They can drive to their own doctor's appointments, and then some assisted livings will offer an in-house doctor. But not all of them do, and they don't have to. The industry has really changed in my 20 plus years here. In the beginning, it really was meant to be a place that assisted with IADLs. It was supposed to be a social support system. Wasn't supposed to be a nursing home. It's not supposed to be a medical support building. And it has become so medicalized over the years to the point that a lot of assisted livings have doctors and nurse practitioners that come to the building to see patients. But again, that's not how it was originally developed, and they don't all offer it, and they don't have to offer it. There's no rule that says they have to have a doctor there. Memory cares tend to have providers, which I think I have another slide that I'll talk about that. And in long-term care, you can't keep your own personal provider. You have to use the ones that are in the building. Almost all the buildings offer a choice, though. They'll have at least 2 attendings you can choose from. Some try to get 3. I know a lot of them around here try to get a doctor that takes care of Summa patients, a doctor that takes care of Akron General Cleveland Clinic patients, a doctor that takes care of Western Reserve patients. So they often will try to do that and keep within the system. And the only way your doctor could come in is if they have privileges. So they would have to get privileges through the nursing home to see you. So it usually doesn't happen. And this is also something that comes up a lot. People will sometimes say, oh, your name was on the paper, but I never saw you. And so how often do you actually get to see the doctor? So at assisted living, there are no rules at all. There's no federal or state rules. So that's up to you and your doctor. And in the memory care units, there are state or government rules that say there must be someone that's on staff or at least available as a consultant to take care of patients, but there's really no rules about how often they have to make visits. For long-term care, you have to come see, when the patient gets admitted, you have to see them every 30 days for the first 90 days, and then after that, every 60 days. And it doesn't have to be a physician, though. An advanced practice provider, nurse practitioner, or PA, physician assistant, can provide that level of care. They can even do that initial admission H&P. But when you're in the skilled care, so you're coming out of the hospital, you're getting rehab, that initial history and physical must be done by a physician. A nurse practitioner could do a visit before that time, but it's not the official history and physical H&P. It has to be done by a physician. And it's interesting because most people don't know this either, that Medicare says that initial H&P has to be done within 30 days of admission, which nowadays seems insane because people are coming out of the hospital still very sick to these nursing homes. A lot of them need active medical management of whatever they had in the hospital that's still going on. And again, they don't have to be seen by a doctor for 30 days. So technically they could come out of the hospital with whatever orders that doctor wrote and not be seen and not have blood work or anything done. But because again, times have changed and people are sicker, most physicians that work nursing homes do come in more often. A lot of them, if they have a private practice, may come in once a week to see patients. People like me who full-time or cover a nursing home with a lot of patients full-time, I'm there a couple days a week. So one building that we go to, we have a doctor there, 4 days a week. So because people are sick, and again, people coming out of there with tracheostomies and peg tubes, and you can't wait a month to see people. So again, that initial visit has to be done by a physician, but every other visit after that can be done by MP, and often is because we're all busy, and the patients just keep coming. The average length of stay now for skilled is around a couple weeks, like 2 weeks. So they come in, boom, boom, and they're in and out, in and out. Next patient's coming in, or just doing admissions a lot. And so we definitely have to do these visits together. The regulatory visits are that every 30-day visit for the first 90 days. So Medicare says if somebody comes in skilled from the hospital, the physician has to do the H&P. The 30-day regulatory visit can be done by an APP, but that next 60-day visit, if they're still skilled, has to be done by a physician. We rarely have patients that are skilled for 60 days these days. But if that happens again, that second visit has to be a physician. All right. So what do physicians do? They can delegate a lot of their tasks to an APP. It says they can't delegate dietary orders to the APP or therapy, but they can delegate to a dietitian and they can delegate to a therapist. All right, what does this say? Oh, patient refuses a bath. So now we're going to talk about ratings, how to rate the nursing homes. Patient refuses to take a bath all week, but then complains when the surveyors come in that she hasn't been given a bath all week. So this kind of stuff definitely happens. There's this website, medicare.gov/carecompare, and it's only for nursing homes, but you can look at their health inspections and surveys, their staffing star numbers, their quality measure numbers. I did find this link for assisted living, but the most recent data is from 2022, and it's just a family satisfaction survey. So there's no health inspection reports on there. And since I'm running short here, I don't want to talk for a whole hour and a half, and I still have a bunch of slides. I'm not going to go into details on the 5-star program, but the 5-star program looks at 3 different things: the health inspections, the staffing star, and the quality measures to come up with an overall star rating that you'll see on that website. The thing I don't like about the star ratings is it's a bell curve, and they have to keep it a bell curve. So even if every building in our community was 5-star excellent and we loved all of them, they would still say only 10% of you can be 5 stars. And the next 2, 3, and 4, only like 23% of you can have those stars. So they keep it a bell curve. So it's hard for the facilities. They're, working hard to get these 5-star ratings, and some of them are very good, but they just can't reach that because some little thing pushed somebody else over. And here's my favorite, Willy Wonka. Come with me and you'll be in a world of OSHA violations. I was going to sing this for you, but I'm kind of, I'm a little hoarse from having a cold. So health inspections, they look at health citations, complaint inspections, and infection control inspections. For the staffing rating, they look at like how many residents are there, how many nurses to residents are there, how many aides to residents are there, how many hours does physical therapy spend with patients. And these are the Ohio averages. So an RN averages 36 minutes a day per patient, and the aides are the STNAs is state tested nursing aides. They spend 2 hours with each patient. Staffing turnover, Ohio averages 56%, which is a big problem that's beyond the scope of this talk. And then this is what it looks like. I'm at Pebble Creek, so I pulled out Pebble Creek's quality measure scores from that website. So they look at how many people were readmitted to the hospital after they were there, how many that were there just for that skilled short stay had to go to the emergency room, and they show, Pebble Creek's average is 10%, and then the national average is 12, Ohio average is 13. So these are the kind of things that you can see on there. How many people are put on antipsychotics for the first time, how many people develop ulcers for the first time, and then how many improved in their ability to move around on their own. And then these are the long stay measures. So the people in the more long-term care part, these are all when you look at, again, the website, you can see all these different quality measures that they look at. And then federal staffing guidelines, they do require that there is a nurse that acts as a charge nurse on every shift. And they require an RN to be on duty at least 8 hours. So a lot of times, again, they might have an RN there for 8 hours, but it'll be LPNs there the rest of the day. And the person that's the director of nursing has to be an RN. And there really is no specific mandate for nursing to resident ratios, although I'll get to that in a second too. And I just threw this in there that to be a nurse's aide, really the minimal training is 75 hours. There's not a big schooling involved with nurse aide training. And I thought this was funny. So the ICU nurses are saying, well, we get 1 to 2 patients, and the ER nurses, we get 3 to 4, and the tele nurses, that's nothing, we get 4 to 5. The med surg nurses will try 6 patients, and the SNF rehab nurse has this face because they have so many more patients. The staffing ratio of 1 LPN is usually 20 to 25 patients. So often they're getting vital signs like once a month. They wait once a month versus, at the hospital, you're getting vital signs every shift. There's usually pharmacists connected with nursing homes that do review everything, and we get notes from them all the time. We've been doing a med review, and we're trying to cut down on the psychotropic meds, and what do you think about trying to reduce this one? Which is very helpful. And then we do falls reviews. Every time somebody falls, there's a team that sits down and talks about what happened, why'd they fall, what can we do to prevent falls. Lab services are offered at nursing home. There's a AHA is the company in our town, American Health Associates, that drives facility to facility and draws everybody's blood and drives it back to the lab. They can administer, and then X-ray. There's a couple companies that come in and do X-rays and ultrasounds and echocardiograms, and then they can have IV fluids and antibiotics. So we try as hard as we can to offer some of that hospital level of care in the facilities so that people don't have to go back to the hospital if they get sick and, get confused and debilitated and all those things. Who says nursing is stressful? I'm 35 and I feel great. Or 39, I feel great. And then this one, I'm going to skip this, but there's an annual survey, and the facilities will run around saying, oh, surveys here, surveys here. You never know when they're coming, sometime between a 9 and 15-month window. They stay for days. They comb through charts. They interview staff. They interview patients. They notice things down the hall, and we'll come back and let you know any citations that you have in your facility. And then there's just some other terminology comes up in terms of regulations. There's something called an SRI. I know when I do medical director meetings with the director of nursing and the administrator, they'll say, we had an SRI, and that means they're self-reporting, to the government, like this occurred in our building and this is what happened and this is what we did about it. And then patients and families can complain, and the state can come in and review that, and they'll call that a complaint investigation. So someone can call and complain about, like it says in there, frivolous to serious. They can literally complain about really frivolous stuff, and state can come in and review whatever they want when they're there. And then the ombudsman is part of that process to help protect people from abuse and neglect. Oh, I'll skip that. And then I don't know if you heard about this, but Biden did have an executive order that went out that he stated in April of 2023. There was a lot of press on it in September, where he said we need more care in these nursing homes, and we need to set standards forth so that people get more nursing hours and more STNA hours. And one of those things was that every facility has to have an RN 24/7. Which is going to be very challenging. I will tell you, we struggle and struggle to find staff to work at this level of care. It is a very hard level of care, people with high level needs. And it's hard because they're there and, everybody eats, and half hour after they eat, everybody's got to go to the bathroom. And there's only so many people that can do this. And so patients all complain, that she didn't come when I hit my call light. And while they're all passing while they're all passing the trays for food and drinks, and some people have to be fed, and, people are like, I have to go to the bathroom. So it's, like I said, it's hard to get enough staff. And same with nursing. It's very hard. You have to pass meds to 30 patients. And while you're doing that, you also get interrupted continuously for all kinds of things. So, and they don't get paid enough to do all this. So I don't know how they're going to make this happen. It says I read on there that part of this is that CMS is going to invest over $75 million in scholarships and tuition reimbursement for nursing workers. So I guess if you want to get some of your tuition paid for, then work in a nursing home for X number of years or something. So I look to see, are there any updates on this? Is this in force or what's happening? And as far as I can see, I don't know that this is in force. I think
it's interesting, Natalie, the CMS and HRSA, the HRSA grant we have, we're actually doing a project on this. We're actually educating around working in a nursing facility. We're doing senior nursing students, STNAs, and social workers. So
Excellent.
with the purpose of, promoting working in a nursing home environment. So yeah.
Excellent. Yay. I'm glad we're a part of it. So does that mean, is that part of this executive order? Like, is this executive order in effect, or
I'm wondering because the
Yeah.
money's there and we've been
Yeah.
doing it. So my
Yeah.
guess is yes.
All right. So I'm wondering, like, at what point I'll have to ask, I should ask my facility before I give this talk, but like, do they have to have an RN 24/7? I'm curious.
Oh,
Because
yeah.
I've been in buildings that like we've been unable to staff an RN 24/7. So
Yeah, interesting.
I should have asked before. I'm sorry. But I will ask and tell Sue and she'll send you an email. And then assisted living's really, there aren't a lot of rules. I could barely find anything. There's not a lot of publicly reported data. And then I found some information on the AL waiver program and kind of what they reimburse for the facilities. So if you're in a assisted living, if again, according to Genworth, if it's a $4,600 a month building, that's like $155 a day someone would pay, and the AL waiver pays somewhere around $130 to $150. So those buildings that are charging $7,000 are probably not going to take as many patients with this waiver. I think this is my last slide. Be kind to your kids because one day they'll choose your nursing home. We used to say that a lot when we were fellows. And now that I have children, I don't like that. All right, so stop sharing my screen. Okay.